Definitely all of us know the answer to this. Diffuse esophageal spasm. Actually, why this question is asked, that in the diffuse esophageal spasm, what we tell you that the characteristic picture is the corkscrew appearance, in which the barium looks spiraling down like this. Okay? If the spasm is very much, in that scenario, we may see pockets filled with barium. Okay? This picture may also be seen with some other diseases like the nutcracker's esophagus. In that scenario also the same picture will be seen. The spiral corkscrew appearance will also be seen in the nutcracker's esophagus. Okay? Most likely the confusions that we have over here, what exactly are the pictures seen in achalasia cardia? One thing you definitely remember is the bird beak appearance. This is the only thing that you remember. Okay? Instead of having the bird beak appearance, you may also see the pencil tip appearance. Something just like you see this pencil, this coming down here, and then ultimately there's a tip. Fine? Along with that, as there is a spasm of the lower esophageal sphincter, the esophagus above the sphincter, what will happen? It will become dilated. And the third thing that you are going to see in achalasia is that there will not be a peristalsis. There won't be any peristalsis. Okay? And now can any one of you tell me that what is the picture in scleroderma? First of all, tell me that what is scleroderma? Scleroderma is a connective tissue disease, right? It is an autoimmune disease. It affects a number of organ systems, and among those organ systems it also affects the smooth muscles. Just try to think about how I am forming the question now. This is what is going to be asked in the exam itself. Okay? Which smooth muscle fibers are affected in scleroderma? The skeletal muscles, the smooth muscles, or both of them? The smooth muscles, not the skeletal muscles. Fine? Now this scleroderma happens in a number of forms. You have read it all, na? Huh? Systemic and localized, right? One of the forms of the systemic scleroderma, which affects a number of different types of organ systems, which is systemic. That means it is going to affect a number of different organ systems. One of those forms is known as the CREST syndrome. True? CREST stands for calcinosis cutis, Raynaud's phenomena, esophageal dysphagia, further sclerodactyly, and T for telangiectasia. Okay? Now this E, esophageal dysphagia. Okay? Scleroderma also causes a motility disorder in the esophagus. The motility disorders in the esophagus, now let us come to this. This is what we are talking now here in the pictures. There are a number of different types of motility disorders in the esophagus. The most common that you remember is achalasia cardia. The second one that you are commonly taught is the diffuse esophageal spasm. The third one that you remember is the nutcracker's esophagus. Now I am telling you the fourth one, scleroderma. Scleroderma may also lead to a motility disorder in the esophagus. Fine? This scleroderma affects the smooth muscle fibers. The esophagus has both the skeletal and the smooth muscles. True? But some part of the esophagus have only skeletal muscle, and some parts have only smooth muscles, and one part has both of them. Which part of the esophagus mainly is composed of the skeletal muscles? the upper one third, and the lower one third, smooth muscles. So now I'll show you a picture something like this. If I have a dilated esophagus that is going down, filled with barium, okay? And now you tell me that scleroderma will mainly affect which part of esophagus? The lower one third. Technically the lower two thirds, but mainly the lower one third. And what will happen to the lower esophageal sphincter in scleroderma? It will be dilated because the muscles are relaxed. This is why the esophagus has become dilated. This leads to GERD, gastroesophageal reflux disease. Ultimately, this repeated irritation of the esophagus leads to the formation of a stricture. Fine? And this stricture leads to dysphagia. This is what you had in the CREST syndrome, esophageal dysphagia. The barium finding in scleroderma is, just think about it, it is very easy. The smooth muscles are gone, what will happen to peristalsis? No peristalsis. Further, what will happen to the diameter of the esophagus? It will increase, the esophagus will appear dilated. Thirdly, what will happen to the lower esophageal sphincter? It will be dilated. Further on, we may also see the strictures, right? And the formation of strictures once again can give you a picture, something very similar to this. But that picture, the stricture will be above the lower esophageal sphincter, not at the lower esophageal sphincter. In achalasia cardia, it is at the lower esophageal sphincter. This is one more picture that you see with the diffuse esophageal spasm. Once again, not the typical corkscrew appearance, which you commonly remember. Fine? Now, the second thing that we have, question number 2, the above, or rather this picture shows chronic pancreatitis. Why is it chronic pancreatitis? We can see the calcification in the pancreas. This is where actually the calcification, you can see it. Okay? And can you recognize the other structures here? This is the liver. Somewhere here is the spleen. These are all the parts of the intestine. These are the kidneys. And this structure that is kept over here is the abdominal aorta, just in front of the vertebrae, a little bit towards the left side. You must have already been told in the radiology classes that the CT pictures always are opposite. The right is left, left is right. So this is what it is, that the liver is on the right side, but in the CT you are going to see it on the left side. Now technically what happens here is that how do you recognize the pancreas? To evaluate the pancreas, spleen and the liver, we give a contrast. The enhancement of all of these three structures should be the same. The liver, the pancreas and the spleen will have the same enhancement. Okay? This is the normal CT. Can you see the normal enhancement? This is the liver. This is the pancreatic body and ultimately the pancreatic tail, which is going back down to the spleen. And mind you, here what you need to see is technically the diameter of the aorta is almost equal to the diameter of the cross section of the pancreas. Normally, the cross section of the pancreas should be equal to the diameter of the aorta, a little bit less or a little bit more, but not very much. If the pancreas appear to be larger in comparison to the aorta, it means the pancreas is inflamed. Okay, there is one question there actually, which you must have seen. Probably it is the next question itself, that what is the most likely diagnosis for this image? shown in the setting of acute pancreatitis. Now you can very easily make it out that what exactly has happened here. Is the cross section of the pancreas similar to the aorta, or is it larger? It is large. And what about the enhancement of the pancreas? Is it less than the liver or more than the liver or equal to the liver? It is lesser, meaning thereby that there is edema. Simple explanation for it. Okay. So what is the answer in this question? Acute fluid collection in and around the pancreas. It is an acute fluid collection. Fine. One more picture regarding it. This. Acute pancreatitis. CT, once again post contrast. We are evaluating it. You can see the diffusely enlarged pancreas, the enhancement, the spleen on that side, the liver on this side. They are almost same. But in comparison, the pancreas appear to be large and filled with fluid because the enhancement has decreased. Okay, this is what what is this? Total security. Along with this, you may also see some calcifications. Okay, now let us go into the disease itself, the pancreatitis. They can show you the picture and then they can ask you that what is the most common cause for this. What is the most common cause of this condition? The most common cause of acute pancreatitis are the gallstones. Okay? Chronic pancreatitis is something else. Now let me change the question further on along for you. What is the most common autoimmune disease that is associated with pancreatitis, acute pancreatitis? Not exactly cystic fibrosis. That is some other question. The most common autoimmune disease that is associated with acute pancreatitis is ulcerative colitis. Actually, three diseases: cholangitis, pancreatitis, autoimmune thyroiditis known as the Riddle's thyroiditis, and ulcerative colitis. They have an association. Okay, four diseases now. The names are acute cholangitis, the ulcerative colitis, acute pancreatitis, and thyroiditis. Which thyroiditis? Riddle's. Mind you that there are two types of autoimmune thyroiditis, Hashimoto's and Riddle's. The one that is associated with ulcerative colitis is Riddle's. It is not Hashimoto's. Fine. This picture, association. Which one are the autoimmune disease? What is the most common cause of this disease? Thirdly, what is the most common cause of acute pancreatitis in young children? I can show you a CT of a child and then tell you that he has presented to you with acute pancreatitis. What is the most likely reason for it? The most common cause of acute pancreatitis in young children is abdominal trauma. Okay? And then one word is used, idiopathic pancreatitis. Technically the word, what happened you ask me, I'll tell you. Any question? Abdominal? Abdominal trauma. Trauma. This is something actually related to your forensic medicine. Have you heard about the battered baby syndrome? What is the battered baby syndrome? Child abuse. They beat the child. The presentations of battered baby syndrome are Fracture the ribs, or rather you don't say fracture the ribs. What we say is that there is a history of repeated fracture of the ribs. The patient is presenting to us again and again. Fine. The second presentation, the child may also present with, and this sometimes happen when you are very caring about the child and you are loving him. What you do is, oh, mera bachcha. Subdural hematoma, SDH. And the third finding or the third presentation can be acute pancreatitis. If a child has presented to you with acute pancreatitis, he is neither alcoholic, the child is not going to drink, neither is he going to, or he is most unlikely to have gallstones. And I am not giving you a history of trauma. It means something is wrong. The child is not going to have pancreatitis. You should always suspect it that there is a child abuse, acute pancreatitis. Now what I was saying was idiopathic pancreatitis. Idiopathic word technically means that we don't know the etiology. But it has been found that the most common gene that is associated with idiopathic pancreatitis is cystic fibrosis gene. Okay? And the question is asked like that what is the most common cause of idiopathic pancreatitis? Fine. And especially in the children, this is going to be very important. Okay? So that's it. Is it clear? Fine. So that's it. Should we proceed to the next thing? And I believe the computer is hanging up. This is a CT of pancreatic pseudocyst. This picture also they show because you did not have the question there. I thought it is better that you see it. You can see the pancreas, you can see the calcifications also here. And this thing that you are seeing here, you can take the slide after the class. Don't worry about it. Don't worry about taking the pictures. Take it with you. Okay? There is no secret into it. This is a fluid-filled cavity. Fine? Why does and what is the cause of pancreatic pseudocyst? What is the most common cause of pancreatic pseudocyst? Actually, why this question is it acute pancreatitis or is it chronic pancreatitis? It may happen in both, acute and chronic. But which one it is more common? Chronic. The commonest cause of pancreatic pseudocyst is chronic pancreatitis, not the acute pancreatitis. It may be seen with both of them. As you can see that this is a pseudocyst with the chronic pancreatitis. Can you see the calcifications here in the pancreas? Right? And the cyst, the aorta, the liver, the spleen, the kidneys once again. So now you have seen so many CTs of this area that you will recognize anything. Fine. What is the procedure shown in this picture? It is just a modification of the Whipple's procedure. Pylorus preserving pancreatectomy. Whipple's procedure looks like this. In Whipple's procedure, technically the disease first of all, why we do it? Normally this is the management of the pancreatic carcinoma. What is the most common cause of pancreatic carcinoma? The most common cause of pancreatic carcinoma is chronic pancreatitis. And the commonest cause of chronic pancreatitis is alcohol. Alcohol is one of the causes of acute pancreatitis. The patient keeps on drinking and he has repeated episodes of acute pancreatitis. Ultimately, this acute pancreatitis gets converted into chronic pancreatitis. Once the chronic pancreatitis precipitates, then there is an increased